This is Dr. Gullingsrud, and I'm going to be showing a video of the technique that I use for all soft cataracts and posterior subcapsular cataracts. These cataracts are quite commonly found these days, especially in people who are younger, in diabetic patients, and in patients who've had prednisone usage. This is going to provide a fast and easy way of eliminating the cataract, increasing patient safety, and decreasing surgical time. The operation starts out, as all of my operations do, under topical anesthesia. I've placed 1% non-preserved lidocaine into the anterior chamber. Here I am placing a dispersive viscoelastic. You can see that my technique employs placing it as far into the eye as possible and then bringing it back to my paracentesis wound, thus eliminating the aqueous from the anterior chamber to fill it fully and flatten the anterior surface of the lens capsule. I like to use external fixation. Watch now as I make my corneal incision. I like to have a square configuration, and will take time to do so. This is a 2.8 millimeter metal keratome. The square configuration that you can see produced will ensure that at the end of the surgery, after I hydrate my wounds, that I'll have good closure, thus preventing influx of liquid and potential bacteria and decreasing the possibility of endophthalmitis or any other infection. I'm going to make my continuous curvilinear capsulorhexis now. You'll see how I initiated in this patient's pupil. The patients that I select typically dilate, person is dilated to 8 or 9 millimeters. I want to fold over the capsulorhexis so that now I can put the Utrata forceps in and grasp the leading edge of my capsulorhexis with the forceps. You're going to see how I'm going to bring it around about 1/3 of the way. I'll then re-grasp it and bring it around another 1/4 of the way. And I'll make my final re-grasp here and bring it all the way around, thus ensuring a nice circular centered opening into the anterior capsule. I always try and instruct the residents to do this in 3 or 4 grasps, thus adding to the efficiency of the procedure. I'm now inserting a 27 gauge flat hydrodissection cannula. You can see the fluid across. I give it a little bit more bolus of fluid. The lens comes out of the capsular bag. I then mechanically push the posterior pole, and oftentimes I'll bring the lens nucleus to the corneal opening. I'm now placing the phaco tip in, and you can see that I keep the phaco tip beveled downward, thus increasing the surface area of contact. I'm now using my chopper. Please now look at the vacuum and foot pedal settings. You'll notice that my vacuum is set at a maximum of 400. I'm primarily using setting 2 and alternating occasionally into setting 3. This is about a 2+ nuclear cataract as well. Oftentimes, if it's 1+ or lower nuclear cataract, I almost don't use the phaco power. In this patient, since it was a moderate nucleus, I'm going to use about 5 or 6 seconds of ultrasound setting 3. You'll notice how the lens will follow itself into the phaco tip. I will use my secondary instrument to mechanically break it up and chop it into smaller bits. But it's a nice, quick procedure, and oftentimes I tell residents, if the lens nucleus comes out of the bag during your initial hydrodissection, well, take it. Use this technique and take it, because if that's what it wants to do, then it's oftentimes best to go with the flow. Again, this is the technique that I use for all of the soft nuclei and posterior subcapsular patients. Thank you very much.